Ms. Hans.
My lady, good afternoon. May I please call Francesca Humi?
Okay, stand up. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Okay, take a seat.
Thank you.
Ms. Humi, good afternoon. You are here today to give evidence on behalf of the Frontline Migrant Health Workers Group, or if I may, FMHWG for short. You have produced a statement for the inquiry, which can be found at INQ 304744919, and that statement is co-signed by the other organisations that make up FMHWG. So is it right that that consists of 2 trade unions and a group of community organisations known collectively as Canlungan?
Yeah, that's correct.
And that you are an affiliate member of that group?
Correct.
And FMHWG represents precarious workers, including in adult social care, such as migrant workers, individuals on visas attached to their employment, low paid and undocumented. And the majority of people that you represent are from an ethnic minority background, is that right?
Yes.
And is it right that you represent people across all of the nations of the UK?
Yes.
And so any evidence that you give today, is that reflective of your individual experiences across the UK?
Yes.
By way of background, if we may, start with some of the data for the adult social care sector at the start of the pandemic. And you have provided some statistics at paragraph 25 of your statement. And if I may just summarise those, it states that in 2019, 35% of care workers and 56% of home care workers were on 0-hour contracts. 1/4 of the national care sector workforce were from ethnic minority backgrounds, and 82% of social care workers were women. Is it fair to say, therefore, that a significant proportion of those working in adult social care could fall within the groups that you represent?
Yes.
Now, the experience of precarious Filipino migrants during the pandemic was summarised in a Canlungan report as follows. While the UK is celebrating care workers and key workers as heroes, the workforce of informally employed migrant carers has remained invisible. So is that an accurate summary of how this group felt during the pandemic?
Yes. And that's because of the visas that they were on. Like you mentioned, they were sponsored by specific employers, sometimes on a health and social care worker visa, but also a lot of our members were brought to the UK on overseas domestic workers visa, which is a form of visa that ties an individual domestic worker to their employer who brings them to the UK. And the nature of that work is happening within a household, within a domestic setting, which means that the way that their work is happening is invisible and has very little public visibility. On top of that, the nature of the work that they're doing, so care work, which ranges from, administering medication, cooking meals if patients aren't able to cook meals for themselves, or, for example, doing personal hygiene, helping them bathe. That is all work that is not celebrated in the UK and is not and does not receive a lot of solidarity from the general public. And so that, combined with the visa conditions, including some of our members who were undocumented, combined with being from an ethnic minority that is not officially counted on the census in the UK. Filipino is counted as Asian other on the census, which means that the community isn't counted, and that any disproportionate impact of a pandemic or deaths from a pandemic can't really be quantified that easily through national statistics. All of those things combined meant that the community was highly invisibilized.
Thank you. Do you think that complex kind of web was understood by policy, by decision makers who are making policy and guidance during the pandemic?
No, I don't think so. I think the problem is that in general, decision makers really fail to fully understand the breadth of the adult social care sector, and fail to understand and acknowledge that, for example, domestic workers, which are part of the domiciliary care workforce, are actually a vital part of the caring workforce and perform work that is required because people want to be able to receive care within their households, within their homes, when their relatives or loved ones can't provide it themselves, and really failed to see that there was a whole chunk of the workforce that was operating on a more informal basis, meaning without formal contracts, sometimes being paid cash in hand, sometimes being paid as low as £2 an hour, and without any of that proper support from the state, or even from employers who sometimes didn't even recognize themselves as employers. And I think government also failed to really recognize how immigration policy was directly negatively impacting health outcomes for both patients and also for the workers who are providing that frontline care.
Thank you. And we're going to return to some of those topics that you've just mentioned there. But how can we ensure, do you think, that that does not happen in a future pandemic?
Yeah, so in the case of migrant domestic workers, it wasn't always this bad. Before 1998, there was a much better visa, which allowed domestic workers to apply for regularization and to renew their visa, and then eventually to get indefinite leave to remain and to sponsor their family to join. The current visa doesn't allow them to do that. That pushes people into exploitative work once they become undocumented, and that leads to very poor working conditions and then poor health outcomes for the people that they're caring for, because people aren't able to work with the adequate support and the adequate tools necessary.
Sorry, if I may just stop you there. I think my question was more, and please, it's my mistake in the way I asked the question, but what I meant was, how can we ensure that their voices are heard in decision-making and by policymakers in a future pandemic?
I think actually, firstly, acknowledging that these communities exist and that they are doing this really important frontline work, and reaching out to community organizations and resourcing those community organizations for their time, engaging with trade unions that represent organizations. I think there's a really strong contrast between the experiences of workers who are members of UVW and IWGB who are able to collectively bargain and unionize in specific care homes versus the experience of domestic workers who work for individual employers and then don't have that bargaining tool. So certainly a strengthening of workers' rights in general. And I think really actually accepting that migrant workers are part of the workforce and should be granted equal workers' rights in the workplace with their British counterparts.
Moving on then to the topic of access to sick pay or alternatives like employment benefits to allow staff to self-isolate during the COVID pandemic if they had suspected or confirmed COVID-19. You've alluded to in your evidence already around most migrant workers, or a lot of them, being on visas with perhaps no recourse to public funds, or perhaps even an informal employment contract. So what kind of barriers did your members face in accessing any financial support for self-isolation during the pandemic?
Yeah, so there's the case of Bella, who is a care worker and is a member of UVW. And she talks about how the statutory sick pay entitlement that she received was not enough. It was below her hourly pay, and that hourly pay was already quite low. And so on top of that, if you've got statutory sick pay that doesn't actually afford people the opportunity to rest and recover from being sick, then your choice is, do you keep working through your illness and earn at least that minimum wage, or do you take time off and then risk not being able to put food on the table? And she talks really powerfully about how that choice was really, really difficult to make. And I'd say, at Ganlungen we represented workers who were working for private households, but also in care homes, who didn't necessarily have that statutory sick pay. And what I've found really striking from hearing about those two experiences, is that actually people who had statutory sick pay and people who didn't have any kind of sick pay entitlement had very similar experiences of feeling like they couldn't afford to actually go on sick leave. They couldn't afford to stop working because of that lack of adequate sick pay and because of all of the costs associated to being a migrant in this country.
And I think one of those examples is included in your statement of from Camilla, who did not have any contractual sick pay. If we could have your statement on screen, please. It's INQ 304744919, page 53, paragraph 166. Thank you. She recalled that some people would say, I feel sick, I don't know if it's COVID or not, but I have to pay my bills. With COVID or not, I have to come to work. Some people said, I can't do the test, I don't care, I need to pay the bills, that's it. And she explained that the home was not really trying to find out if people were sick, as the reality was that they needed staff to come to work, as they could not afford the higher agency rates paid for cover staff. So did you hear examples of people going to work with COVID-19 symptoms or returning to work earlier than they might otherwise have done, perhaps due to their own personal circumstances or due to staff shortages?
Yes, people felt that they couldn't take the sick leave that they really needed in order to recover. They felt that they had to keep going because they knew that there were massive shortages within the care homes, and that if they didn't return to work, then, who would be able to cover their shifts? But I recall having a phone call with a Ganlungan member, and she called me because I was supporting her with her immigration status, and she told me that she was working as a carer for a private household, but that she was feeling really sick. And on the phone call, I could hear her coughing and struggling to breathe. And she said, I can't take the time off because I have to work tomorrow, because I need to be able to pay, I need to save money so that I can send remittances back home. I need to save money so that I can renew my visa. And I really had to kind of talk her out of going to work and saying, if we can order a test to your house, if we can get you groceries, if we can get you medication that would cover you for at least a week, will you promise me that you won't go to work and that you'll isolate and just rest and take care of yourself? And she agreed, and we were able to deliver that support, like that care package to her house. But if I hadn't been there to speak to her, she would have gone to work and continued to work. And, care workers understand the risk that brings, but when you're trying to decide between, having food on the table and supporting family back home potentially, versus not working, it's a really, really difficult decision to make, and they weren't being supported by their employers either to take that time off. That responsibility is also on the employer to be giving people sick pay, especially if they're expecting personal care work during a pandemic. It's normal that your carer might get sick.
I think another topic that you've explained was affected during the pandemic, in particular due to what you describe as chronic understaffing, is work allocation and changes to individuals' responsibility. So if we could have your statement on screen again, please. INQ 304744919, page 16, paragraph 42. You say this: outsourced workers, typically working through agencies, were frequently relied on to fill the gaps when pre-existing staffing shortages worsened during the pandemic. It was widely reported that they had to take on increased workloads and job variation without training or consultation, including, for example, the provision of medication to care home residents. Are you able to help us with what impact that had, that change of responsibility and work allocation on staff and also on residents' care, if you know?
So this meant that care workers in care homes were being asked to do work that was outside of their remit, outside of their qualifications or training, and that the risk was being passed on to the least well-paid and to the most already exploited part of that workforce within the care home. So again, Bella, who's a UVW member, talks about being told by the nurses that, well, if you're already going to go and do personal hygiene for this patient, then you might as well be giving the medication because, the care home had clearly made an assessment that some staff were okay to expose to higher risk as a way of safeguarding the rest of the staff from exposure to COVID. And we spoke to another care worker, Lorena, who is a member of the Filipino Domestic Workers Association, and she experienced the same thing of being told by the nurses, here's the medication, you go into that room and you give it because I don't want to go near that patient because we think that they have COVID. I can't necessarily speak to the impact that had on patients, but from speaking to those workers, they did not feel good about that. And also there's a fear of, what the responsibility that they're being given. And also if you're going to be asked to do work that is above, your current duties or your roles and responsibilities, then you also need to be paid at a higher level if you're going to be taking on more responsibility, and that clearly didn't happen.
And did they report to you whether they received any additional training to carry out those responsibilities?
No, as far as I can recall, none of the people that we have spoken to in the context of Module 6 receive further training. And actually, on the contrary, we spoke to several workers who told us that they, at the very beginning, requested training, wanted to understand more about measures to prevent the spread of COVID-19, and asked, care homes or their employers, what would be the specific plan to stop the spread of the virus, and they were refused, and that training did not take place.
And to your knowledge, did that continue, or was that training provided but later on in the pandemic?
I'm not sure.
Okay. You've briefly touched on it there, but you have referenced in your statement as well that you had understood from some of your members that they had been disproportionately allocated to areas with a high risk of infection and care homes. Are you able to get an idea as to how widespread that was amongst your members?
Across our members at Ganlungan, it really felt like the whole community was being put on the front line, and our evidence from Module 3 also attests to that, but for the healthcare sector. And one of our members, who was based in a Kent care home, was systematically allocated to high-risk patients. She was a nurse in a care home, and she was systematically being allocated to high-risk patients, to COVID-prone patients. But I think it's also that it's about the allocation, but it's also about the nature of the work. If you are a domiciliary carer or domestic worker and you're going to people's houses, then the nature of your work is going to expose you at a disproportionate rate, especially if you're not living in with your employer and you have multiple employers and you're taking public transportation to go to your different patients' homes, then that is increasing the amount of exposure that you could be facing with every job that you have.
And you have provided some examples in your statement of the impact that this had on the mental health and well-being of some of your members. And if we could have on screen, please, INQ 304744919, page 29, paragraph 78. This is coming back to Camilla. And she reported that she'd been working every day on a 12-hour shift, having usually worked 3 days a week. And she said, my mental health was not all right. I wanted to have a break from the care sector and I didn't feel safe. Every day she got home from work exhausted, but had to immediately wash her uniform and get in the shower each day to protect her family. Other members who have been included in your statement have reported feeling in constant fear of falling sick with COVID, and some of the other issues that we've already discussed around the fear of not being able to go to work. Was there mental health support for your members that were working in adult social care?
So Kenlingen took it upon itself to provide that mental health support. And when I started working there in 2020, we were just starting to have programs to support Filipino frontline workers in Tagalog, so in one of the national languages of the Philippines. And we thought that it was so important for workers to have a safe space away from their employer, to talk about what was going on at work, to process grief, and to get basic mental health provision, because firstly, it's very difficult to get mental health support through the NHS. And on top of that, for workers who are undocumented, they couldn't access that mental health support through the NHS anyway. But there were some cases where maybe their employers were able to provide it. I know that the NHS opened up a phone line with Filipino language speakers available, but the uptake was very, very low because people were so concerned that if they talked about how difficult their working conditions were, if they talked about how they were being bullied or systematically allocated to COVID wards or COVID patients by their manager, that it would get back to them, and that there would be negative consequences for their work and then therefore their visa, because their right to work also controls their right to be in the UK.
And do you have any suggestions as to how that could be improved if there were a future pandemic, to ensure that they did feel confident coming forward?
I think something that would be really important is a firewall, so a mechanism through which the NHS guarantees patient confidentiality with regards to both employers but also with data sharing with the Home Office, because people worry that if they present themselves to the NHS and they're undocumented, that they're also going to be reported to the Home Office and detained and then deported. And similarly, that there are ways of safely reporting what is going on at work without that fear of immigration enforcement. The impact of immigration policy cannot be overstated on how it impacts migrant workers in all aspects of their life, including mental health.
So I'm sorry to interrupt.
Yeah.
I thought that in M3, I heard something about there being some provision whereby data would not be shared with the Home Office. Was there not? Have I misremembered?
I think so. The basic mechanism of charging in the NHS, so through which patients who haven't paid the international health surcharge are charged 150% in order to access the NHS. That basic level of data sharing is still in place because each hospital or NHS trust will have an overseas team that assesses patients about whether or not they need to pay that surcharge or to pay that 150%.
But I thought the surcharge was lifted for all COVID patients.
It was, but then it wasn't lifted for long-term, like secondary, what's classified as secondary care. So, for example, if you have long COVID, then the surcharge would still apply, and it was lifted for vaccine access as well. But there was such a level of distrust amongst undocumented community members that they didn't feel like they could safely get the vaccine, the NHS, because there was still that fear that they might be reported.
That I understand, the level of distrust. But what I was just trying to get at was what was actually in place and what wasn't.
I can't speak to that because I can't remember off the top of my head, but I know that for Module 4 we submitted quite a lot of evidence on that, so that's what...
I'll check the evidence.
Yeah.
Thank you.
Thank you. So one of the other topics that you have addressed in your statement, which the inquiry has received lots of evidence about already, and that's around restricting staff movement between care homes. And in your statement, we don't need it on screen for the moment, thank you. You said that the control measures put in place often failed to appreciate how common it was for care workers to have more than one workplace. This meant that care workers frequently travelled between care homes on public transport and were unwittingly able to carry the virus from one care home to another. And one interviewee noted that the phrase that was used at this time was, "The carers are the carriers." Would it be right to infer from that evidence that many of your members were not able to follow the guidance on restricting staff movement?
Yes, and for a lot of cases with our members, that guidance wouldn't have applied to them anyway if they were working for like individual households. I also think it's really important, like that framing like needs to be pushed back on, because it is, if the sector is pursuing profits over patient safety and over staff safety, then they're going to be making decisions that prioritize profit. So, for example, not providing enough sick pay, not providing people with PPE, not providing people with like testing and tracing. And so it's the for-profit care sector that is the carrier of the disease. It is not the workers, because they are being submitted to their working conditions, and working for a for-profit care sector pushes profits to be prioritised over care and over safety.
Did your organisation or the others that make up FMHWG take any action to raise the issues that your members were having with complying with the guidance?
I can't speak off the top of my head for IWGB and UVW, but at Gandungan we engaged with the Hackney civil society and voluntary sector meetings that they were organising with Hackney North East London, the NHS North East London Trust, and we also engaged with the Greater London Authority. We met with Sadiq Khan, and we also gave evidence with the London Assembly about the impact of COVID in general on the community. But it was we also submitted evidence. I can't remember exactly what the title of it was, but I think it was in 2021, the government called for submissions and evidence on racial disparities and racial inequalities in the UK. And we submitted evidence to that report to highlight the impact of COVID on the community.
Was any of that particularly in regard to restrictions on staff movement that you can recall?
It not as I can't recall right now.
No, that's no problem. It has been suggested to the inquiry by Matt Hancock that one potential way to improve staff restriction in future could be for two care homes who may currently employ people part-time to instead take fewer people to work full-time, whilst also allowing someone in a care home on a 0 hours contract to do another role somewhere else if there weren't any hours coming from the care home. Do you think that would be practical or even possible for your members?
I don't think so, because of the way that the immigration system works, where people are being sponsored by a specific agency or a specific care home, and because of the overrepresentation of migrant carers within the care sector, I think that could be very, very complicated actually to put that into practice. But also I think the priority would be for people to have better pay and better working conditions, and as part of that, better sick pay, not just this consolidation, which, you know, I can't speak to how that would really work in practice.
Thank you. We've briefly touched on the topic around training for clinical care and additional responsibilities that some of your members were asked to take on. I want to briefly ask you about training on following and implementing IPC measures and the use of PPE. now either from employers or the NHS or perhaps even voluntary organisations. So are you aware of there being any training on those topics for members that were working in care homes?
No, I'm not. And in fact, a lot of our members, both UVW and Ganlungen, had to make their own PPE because they weren't getting access to the right kind of PPE at the time, or enough PPE.
Sorry, I was just asking about the training for the moment.
Yeah.
Training on the use of PPE, donning and doffing, but also around following IPC measures. Were you aware of training for those topics?
No, not as far as I'm aware.
And what about for domiciliary carers? Were you aware of any training for them?
No.
Do you think it would be helpful to have training perhaps outside of a pandemic on those topics to prepare for a future pandemic?
Yes, definitely. But I would question how that would be possible given the current care sector is so fragmented, and it's private companies, private care homes who then employ agency staff, and there's a level of fragmentation and privatization that means that I don't know how it would be possible to get that staff training equally delivered and across the whole sector in the same way that, if there was some kind of NHS training for nurses, for example, that could be much easier to deliver because you have one solid workforce that then can receive the same quality of training.
A slightly different topic now, if I may, and that's just around guidance that was issued by the government and public health bodies. Was it available in a range of languages from the outset?
No, it was available in some languages, but Ganlungen had to lobby and push for Filipino to be one of the languages that they systematically translated the guidance in.
Do you know when that started?
I think it would have been in either spring or summer 2020, because we were already seeing the high death rates in the community, and Ganlungen was doing a community death monitoring project because we felt that the deaths that we were experiencing in the community weren't being properly accounted for.
Yeah.
And so that was around the time that we realized, okay, the community is being disproportionately impacted by COVID-19 because of the frontline nature of their work. And part of that was because of working conditions and immigration policy, but part of that was also lack of resources in community languages.
And we'll return to that topic in a moment. If I may just ask you about the adult social care risk reduction framework, which the inquiry has heard about, which was produced by the Department of Health and Social Care and published in June 2020. And that was intended for use in all social care settings or social care interventions, and was guidance for employers on how to support workers who were more vulnerable to infection or adverse outcomes from COVID-19, including due to ethnicity. So were you aware, or were your members aware of the existence of the framework?
No, and I think that's quite damning, actually, that we, UVW, IWGB and Ganlungen, represent a very wide range of care workers across different settings and across different workplaces. And in all of the consultation and community engagement that we did at the time, but also that we've done in the context of this inquiry, it didn't come up once.
How do you think awareness could have been improved for that sort of initiative?
It's a good question. I think working with unions and working with community organizations that have that inbuilt trust with their members would be a very powerful way of making sure that that message is being delivered. But I just, again, because of the nature of how fragmented the care sector is, a worker might be getting training with one of their employers, with one of the agencies or one of the care homes, but then are they receiving the same message or the message in the same way with their other employer? So I think going through unions and community organizations would be really key.
And in general, do you think that the increased risk to COVID-19 for individuals from ethnic minority background who work in the care sector was properly recognised in the guidance and in local actions that were taken to protect staff and workers?
No, I think in general it was not adequately recognised, and I think the recognition that, you know, our community members were getting in the media, for example, or even through like policies that some of the policies that were taken up was really because, as you know, speaking as a member of the Filipino community, we were pushing and pushing and pushing and trying to raise the alarm in every way that we could.
You touched briefly a moment ago on some of your members' experiences of access to PPE, and you've included some of those examples in your statement. So if we may have on screen, please, INQ 30474-919, page 49, paragraph 145. And this is, again, Camilla's experience of working at a care home, where she said, I used a machine to laminate. I then got some elastic from one of my leggings, as at that time we were not allowed to buy anything, so we put it around my head, and I had to help my colleagues with this. I had to use the laminator. Later I improved this with putting some foam around the head. And then at paragraph 146, she recalled that they had to use plastic shoe protectors for their hair, and that the sanitizer gel that they were given burnt their hands with how much they were being asked to use it. And then at paragraph 147, she reports that they were eventually provided with masks that were given one single-use surgical face mask for each 12-hour shift. And she and Victoria recalled that they were supposed to change their mask regularly, but were unable to do so because of shortages, and that many workers had similar experiences. So were those kind of experiences widespread amongst your members?
Yes. So members of the Filipino Domestic Workers Association, which is now the United Domestic Workers Association, made their own face masks. One member taught herself how to make face masks by watching YouTube videos and getting the supplies, and made about 50 face masks for members. At Kanlungan, we distributed face masks to members, and they would have been part of the care packages that we were giving to members who were isolating. And also, not just were people having to make their own PPE or source their own PPE, but in some cases, workers were reprimanded for wearing PPE in their places of work. So one Kanlungan member, as early, I think, of January or February, when COVID started to be gaining international attention in the media, was very, very anxious about it and sourced her own face masks and came to work and was told by her manager to take it off because it would scare the patients. And I mean, I can't imagine being, you're trying to protect yourself, you're trying to protect your patients, and you're told by management that essentially that you're doing the wrong thing. And we heard a lot of similar evidence of people having to source their own and then either being reprimanded or being told not to wear it, or having to make their own out of inadequate materials.
And was that the same across domiciliary care and care homes and amongst those that were employed and outsourced agency workers? Were you hearing the same issues from all of those areas?
Yes, so especially for domiciliary carers, their employers, again, because I think a lot of these employers didn't really consider themselves to be employers, so they didn't think of themselves as having the normal responsibilities towards a worker that other employers would have. So they sometimes wouldn't source PPE for their workers, or again, if you're working across multiple households or multiple employers, then it's also easier for the employer to pass the buck and be like, well, if if you're doing more shifts with this employer, then maybe they should be the one sourcing it, or this isn't, you're not actually a worker, this isn't that kind of arrangement, so I'm not going to provide it for you. But also we heard cases where employers were willing to provide PPE but weren't able to source it because they were having to buy it at the shops like everyone else. There was no system for them to, get priority access because they were employing a care worker.
And another area where you have described problems that your members had was around access to COVID-19 testing. And you've described it in your statement as a general unavailability, which forced the group's members to seek out public testing facilities. But what you have also explained in your statement is that there was some fear amongst some of your members around registering the test results or taking the test at all. So first of all, when did access to COVID-19 testing improve for some of your members working in care homes and in domiciliary care?
I can't say for certain, but I would hazard a guess that it was probably once that first big wave and lockdown was over, but maybe we could check the evidence and see if there's anything specifically about that.
And were you aware of individuals or employers choosing not to take a test for fear of what we have already discussed around registering the results, or that it could be positive and not, and therefore not being able to attend work?
Yes, people were scared of testing because of that, but also they were scared of registering because it was on the NHS website, and they were scared of giving their name to the NHS. Some of our members had been undocumented for 5-10 years with very little contact with state institutions. And then on top of that, you're dealing with the stress and the fear of the pandemic. And then you're being told that now actually you can trust this institution that, you've been told previously would share information with the Home Office. But now you should register and give your address and give your name so that you can get a test at home. So we would often assist people with ordering the tests on their behalf so that, that risk was elated, and we tried to make it as clear as possible that, they were not gathering that information, and that information, as far as I'm aware, was not passed on for immigration enforcement.
Thank you. Your statement and evidence has highlighted some of the immense work undertaken by the organisations that make up FMHWG to support its members, and you've summarised some of that work in your statement as well. Are you able to provide us with an example of some of the support that maybe each organisation provided that really made a meaningful difference to the community? So,
speaking first for Kenlongen, I'd say that the biggest work that we undertook was organising pop-up vaccination clinics for community members, and we did that in partnership with Hackney Council, and that was genuinely, life-saving work, because people who previously thought that they wouldn't be able to access the vaccine, and especially for people who were working in the care sector and who'd been told that if they didn't get the vaccine that they wouldn't be able to work, that they'd have to provide proof of vaccination in order to keep working. People were really scared of, basically the choice as well, not get vaccinated and then lose your job, or get vaccinated and risk being reported to the Home Office and then detained and deported. And so having that vaccination clinic meant that people were able to safely access the vaccine. We had one person who came all the way from Scotland so that he could be vaccinated. But we also did a lot of immigration support and campaigning, and we really pushed for all undocumented people to be regularized, to be granted status so that they would be able to access the healthcare system equally and on an equal basis to any other person in the country. And we also did a lot of firefighting around issues around regularization and some sort of fraudulent people claiming that you could apply for amnesty if you just paid £5,000 and then that would get you your visa, because they were taking advantage of the fact that the government had labelled it a vaccine amnesty for undocumented migrants, which then led to a lot of confusion because that was taken as like amnesty in terms of your immigration status. So I'd say that was the biggest work that we were doing. For IWGB and UVW, I know that they were able to unionize staff in care homes, and through that they were able to actually get better working conditions and better contracts and pay for their members. And I believe that IWGB was also involved in a judicial review, but I can't remember it off the top of my head.
That's no problem, thank you. That's very helpful. And there are just two more topics I wish to cover with you. The first one is around workforce deaths in the care sector. Now, you've briefly touched on this already, and how your organisation forms the view that it was difficult to count the numbers, and that perhaps the true mortality rate wasn't known or wasn't being reported. And I think you've said in your statement that it must have been significantly higher than recorded. Can I ask you what informs that belief?
So the way that we were monitoring the number of deaths amongst Filipino migrants in the UK was by searching on the news, including local news, looking at NHS Trust websites to see when they were announcing staff deaths and if they disclosed the ethnicity of the person. We also scoured Facebook groups and other forms of social media, and then whenever we had doubt, we would try to contact a relative and try to get that confirmation. That is an actually flawed process, and there were certainly community members who died that we weren't able to count. And also because, for community members who were undocumented, then their deaths wouldn't have been reported, and if they weren't being shared on Facebook groups, or if people in the community didn't come to us to ask for support. So we were sometimes contacted by family members actually in the Philippines, asking to cover funeral costs. And
Take a drink. Take your time.
We were being
Deep breaths.
we were being contacted because they didn't have anyone else to turn to. And many came forward, but certainly others didn't. And that would have slipped through the cracks. And on top of that, it wasn't data that the government was actively collecting, because that would have been very damaging for them. But, we were able to get access to some data and some statistics that told us that in May of 2020, 22% of all COVID-19 related deaths amongst NHS nurses were Filipino, despite Filipinos making up 3.8% of the NHS nursing workforce. So that's a really disproportionate impact. And then that same research from the Health and Science Journal, which I'm just going to read so I don't get it wrong, but it found that 83% of ethnic minority health and care worker deaths were migrants, and 36% of those were from the Philippines, which is huge.
Yeah. Ms. Humi, would you support improvements to the collection and quality of data on ethnicity of the adult social care workforce, including migrant healthcare workers, in future?
I think, yes, Ganlangan would support that, but I also, that is not the only solution, because if people who are on precarious visas continue to be exposed to disproportionate risk, even if you've got great data about it and you can count those deaths, it's not going to actually prevent those deaths happening in the first place.
The final topic that I'd like to ask you about is around a mandatory register of the adult social care workforce for England. In regards to whether it is mandatory in Wales and Scotland, to your knowledge, did that cause any problems for your members who are perhaps undocumented migrant workers?
I don't know if the register would have if that process would have even been able to contact them and, actually register them. So I'm really not sure.
Would you have any concerns about it potentially deterring people from joining the profession from the backgrounds of the people that you represent if there were a mandatory workforce register in England?
Yes, it would, because if people who are currently undocumented or have really precarious immigration status had to register, then I would imagine that would prevent a lot of people from entering the care sector. And also it's like, on paper it's a good initiative and it's a good idea, and I think care should be regulated in a way that improves health outcomes for both patients and workers. But the reality is that people hire undocumented people or people with limited leave to remain or precarious immigration status because they know that then they won't have to pay them minimum wage. Like I said, there are people that I worked with who were being paid, £2 an hour, or living in and therefore being on call constantly. And so part of the appeal of hiring someone who has a precarious immigration status is knowing that they have very little ability to push back and to fight for their rights, that if they're working for an individual household, there's limited bargaining and unionizing power, and also in terms of pay, that people can get away with paying people very, very little because they take advantage of that situation. And so creating that register, I really wonder what that would do for people who maybe want to be, who don't want to be paying people more or maybe can't afford to do that, and actually relying on our community members very much.
You may feel that you've already answered it, but do you have any suggestions for how some of those barriers and issues that you've just identified could perhaps be overcome to support people to join such a register?
I mean, it's always going to come down to immigration policy. And so actually facilitating regularization for all people, going to a pre-1998 overseas domestic worker visa so that people can actually continue to renew their visa and then be regularized. The government has announced scrapping the health and social care worker visa, which I'm not sure isn't going to improve the working conditions of people working in the sector right now. But this system of tying individual workers to their employers, and that being a way of controlling the worker as well, just has to stop. And that would be a key way of actually improving the working conditions and improving people's human rights and dignity and their ability to thrive in this country.
You have provided a list of recommendations in your statement for which the inquiry is grateful. And obviously we've already discussed some today. Are there any others that you wish to highlight now?
I haven't touched on this explicitly, but the no recourse to public funds condition needs to be scrapped, because actually one of the reasons why statutory sick pay is so inadequate is because people who are on visas in the UK can't access other public funds. So if you were to develop a long-term disability and you wanted to access benefits to support your life through welfare support, then you're actually not eligible for that. And support for long COVID falls in that category.
I think maybe going beyond scope here.
Yes. Are there any others?
The group is pushing for a national care system similar to the NHS as a way of actually creating a more cohesive and equal workforce.
Thank you, Ms Hoomey.
Thank you.
My lady, those are all the questions for Ms Hoomey.
Thank you very much indeed for your help, and for the help that obviously you supplied to your members during the pandemic. I hope you haven't found it too distressing.
That's okay.
But it's been really helpful, and I'm very grateful to you for coming along today, and obviously for the material in your written statement. And don't worry, if, as I often do on the tube on the way home, you realise something, we'll take into account what's in your written statement.
Okay.
So thank you very much.
Thank you.
I think it's probably best if I rise now for our afternoon break, albeit a bit early because of the next witness coming.
Grateful, my lady.
I shall return at 5:02.
Rise.
Indeed, my lady. May I please call Joanne Sansome?
Okay, if you repeat after me, I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Sansome, thank you so much for coming over. I gather you've flown in specially today to join us.
Yes.
And thank you for the help you gave us for the impact film too. I was watching it again earlier today. So thank you for coming along, and thank you for what you've done so far.
Thank you.
Cecil.
Thank you. Ms Sansome, you are here today to provide further evidence in relation to your experiences during the pandemic. If I may begin, you describe yourself as a person with a disability. And what condition do you have?
I have cerebral palsy.
Thank you. And in terms of your background, you explained that in 2016 you completed your Masters at Queen's University Belfast, exploring the participation of disabled people within public and political life.
Yes.
And since that, and indeed before then, you worked to further awareness and understanding of disability rights. In that capacity, you are an active member of the Disability Research of Independent Living and Learning, otherwise known as DRILL,
Yes.
and the National Advisory Group of Northern Ireland. And you continue to be a member of the Northern Ireland Social Care Council Participation Partnership, and you, along with a variety of other advisory roles that I won't go through now, but they're all in your statement. In that capacity, you've also helpfully provided to the inquiry a witness statement on behalf of Disability Action Northern Ireland. That, of course, speaks to the wider impacts of the pandemic.
Yes.
And in due course, of course, my lady has already seen that statement and it will be published. But today we're here to concentrate on one aspect of that statement, which is the impact of the pandemic on you and your experiences. Thank you. In addition to the impact film that my lady has referenced, you've also contributed to the inquiry's record for this module of Every Story Matters.
That's right.
Thank you. If I can begin then by focusing upon the aspects of social care that you received during the pandemic. Firstly, may I start by asking, what type of accommodation did you live in? And
I live in supported housing in South Belfast. It's 24-hour support, and it's domiciliary care, but it's supported 24/7. And there's 22 people that live in the building, and the accommodation ranges from self-contained apartments to one-bedroom ensuite and shared communal areas.
And my understanding is that you have one of those apartments within that building.
Yes.
And in terms of domiciliary care, you have care to support your personal needs.
Yes.
Is that right? Can I take you back then to March of 2020?
Yes.
The outset of the restrictions that came into force. In the impact film for Module 2C, you state that for you, the pandemic started on that day, the 15th of March, and that day was your last day in society. What did you mean by that?
Well, that day, when I got up, I had no clue of what was ahead of me, and I was going shopping with my dad, which was my normal for my food shop, and on the way to the store, it came on the news, and me and my dad always went for a cappuccino after we did the grocery shop, and whenever we were in the cafe, I remember saying to my dad, "Oh, we may enjoy this in case it's our last cappuccino for a while," but I was joking. And then when we got back to my supported housing, the manager was waiting on me coming back, and she said to me, "We're going into lockdown." And I was like, what does that mean? And she said, "Oh, it means you won't be able to go out, and no one will be able to come in."
How did that make you feel?
I was kind of in shock. I didn't really know what to think. And I said to her, "But will my dad still be able to come? Because I have food intolerances, and he does most of my cooking, and freezes it for me just to eat." And she said, "Oh yes, your dad will be your designated COVID supplier for however long." And I said to her, "What does that mean?" And she said, "Oh, he'll be able to bring you stuff, but he won't be able to be with you." And I said to her, "How long will that be for?" And she said, "We don't know yet." And so Dad went home, and I thought it will only be for maybe a few days till we sort something out. And it was my birthday on the 27th of March, and it still wasn't sorted. And I was like, "Is anyone allowed to come for my birthday?" And at the beginning, I had to pick a day for my dad to come as my COVID supplier. And I jokingly picked a Friday because I knew my birthday was on a Friday, because it was close. And so they let my dad in to put my presents into my flat, but I had to go and sit in the bathroom if he was in my living room, or outside if it was a nice day, while he was in my flat putting stuff away. And I used to call it the Fabulous Food Fridays. That's what it became known as during my lockdown period, which was far long, 700 plus days. And I only know that because I kept it like a diary. So, yeah, it was long.
Just picking up on your Fridays, those were the days that your dad visited as effectively
Yeah.
your weekly permitted essential supplier. And each Friday he would bring treats,
Yes.
baked items from him and your mum. I believe that became known more widely as Fabulous Fridays, the treats. Is that right?
Yes, because he made treats for all the care staff too and things. I guess it was their way of showing appreciation and helping in some way, but it was just weird. It was very weird. And as time went on and restrictions didn't ease, the support building started to allow people that were normally office workers within the support service to come in to have do cleaning and have coffee with us. And I don't mean this sounds bad, but part of me resented it because I was like, if they can come in with a mask, why can't my mum and dad? So yeah, it was just very, it didn't make sense. It didn't make sense.
So effectively, office workers were coming in to have chats and provide company, but that was at a point when the restrictions meant your mum and dad were not able to visit and see you.
Even though they were on furlough.
Just turning to your dad and picking up on what you've just explained in relation to him being your permitted essential supplier, he also, in addition to providing treats and obviously seeing you, was involved in cleaning your apartment. Is that right?
Yes.
He sorted out the laundry exchanges for dirty and clean clothes.
Yes.
And also brought other weekly supplies and organised those for you. How important was it to you that your dad could continue to assist you in those ways?
It was very important because even though I wasn't allowed to be in the same space as him, it was different from being on screen, and I guess it allowed me to keep some sort of normality because I was still getting the same food, things like that you wouldn't normally think about. Like he was able to tell me how my mum was, how my brothers were, without a whole host of people being on screen along with us if we were on a family Zoom call. So even though we weren't in the same space, it still allowed me to have a bit of a connection, I guess.
There was still some level of personal contact that you were able to have, even if you were, as you explained, sat in a bathroom while he was sat in your living room.
And sometimes my mum phoned me while I was in the bathroom if Dad was hoovering or whatever. And it was, I can't really explain it, it was just really surreal. I think I'm back how long it lasted for too. 700 days and more is a long time. I kind of stopped counting after the 700.
It is a very long time. Can I ask you about the domiciliary care package that you had? So in addition to your dad supporting you, you received care within your apartment.
Yes.
What impact did the lockdown and the restrictions and the pandemic generally have on those services?
It had a lot of impact at the very beginning, especially because staff were getting sick, because there was a shortage of PPE at the very beginning too, and it was so scary because we were being told to keep social distance and whatever, but a lot of my own calls are very close contact in nature, so whenever they had no PPE or they were wearing cloth PPE that you were being told wasn't effective in the media, that was really frightening. And I guess I was lucky in a way because of my ties with Queens. I was able to reach out to the COVID team at Queens, and they got us some PPE alongside another organisation that made the cloth ones as well. So, but that was definitely the most probably scary time because it was just at the beginning and all you were hearing on the news was people dying, and yeah, it was scary.
And that's, when you say Queen's, that's the COVID-19 team at Queen's University in Belfast,
Yes.
isn't it? And it's, in fact, the supported housing accommodation was finding it difficult to get PPE. There was a shortage, and you effectively made those contacts to secure some.
Yes.
The inquiry has also heard evidence about staff shortages during this time. Was that a problem in your supported accommodation?
Yes, there was one day in particular, I remember that there was only 2 staff on the whole day for all 22 of us, and they did their best, and it was crazy, but I at that time I just kept thinking about my friends in other situations that lived in their own homes but needed care, and they weren't getting any care. Like, I know some people that were stuck in bed for days at the beginning because of the shortages, and again things what able-bodied people would take for granted, things like partially sighted or people that couldn't read their mail. They weren't getting stuff like that read to them anymore, and it wasn't seen as something essential. And I know of one person that had both him and his partner are blind, and they have 2 children, and one of their children had a rash, and they phoned their GP, and the GP told them to take a photo of the rash. 2 blind people take a photo of your child's rash. So it was stuff like that, because they didn't have any support worker at that time to take the photo for them. So things like that need to be considered.
Absolutely, and we've heard, Mrs Sansome, other evidence in the inquiry that things that were considered non-essential in terms of life-sustaining aspects of care were certainly by some local authorities unable to fulfil at various points. So that certainly is evidence that the inquiry has heard more broadly as well. In terms of the impact upon you, obviously you receive personal care of different types. Am I right that that affected things such as your ability to have showers, to clean, to do all of those things for yourself as well?
Yes. There was days you weren't always guaranteed a shower or your full care, allotted care time for that day, and the staff really did their best, but sometimes it wasn't possible. So definitely going forward, I know the pandemic was unprecedented and whatever at the time, but going forward, things like that need to be planned for how to mitigate those type of situations. I'm not really sure what that would be, considering the hospitals were so crowded with COVID itself. So I'm not sure, but that needs to be something that's co-produced and co-created and co-designed with people that use the services.
And that is one of your primary themes of your witness statement, is the need for proper co-production.
Yes.
With people who have disabilities and their carers.
Yes, because we understand what we need. We live it. Other people might see a specific element of it, but they don't live the whole thing. So you can't legislate for what you don't know or only understand in part. So to get the holistic picture, you need a collective voice, and that's what co-production and deliberative democracy has the potential and the opportunity to deliver, and that needs to come out strong in the report, in my opinion.
Thank you. May I turn to pick up on the impact of the visiting restrictions? You've touched upon them already in relation to not being able to have your family to visit. But what you do describe in your statement is that your laptop became your digital window to the world in that regard.
Yeah.
How successful was that to communicate with family and friends?
Sometimes it was fantastic. I had so much positive experience out of being able to use my laptop independently. I always wanted to go to CRIP camp in America. It's a camp for disabled activists, and it's run in California every year. And for one reason or another, I was never able to go. And during the lockdown, they run a virtual CRIP camp, and I went every day. And we had a ball. It was fantastic. And I've still kept in touch with so many of the activists that I met during that summer. And we also met with Barack Obama as well. So it was just a real good experience that came out of COVID, I guess. So it's important to highlight that too. There were some good things, and that was one of them. It brought the disability community very much closer together as a global community fighting for equality and rights that we had tried before but never succeeded. But the technology that emerged due to COVID allowed for it, and sadly it has fell away a little bit, more than a little bit, since the world has got back to the so-called normal. But sadly, despite all the promises of everywhere building back better, I don't think we have in relation to certainly the community of people with disabilities. I think our legislations and our rights haven't been updated in any way significant, and in actual fact, I think there's been a huge rollback with our rights and the benefits and the welfare reforms. So I don't think they're living up to that statement, build back better. And that's sad, because that rolled off their tongue every day during the pandemic, and there's no evidence of it in my opinion.
Ms. Sansome, if I can just pick up on one of the things that you've just mentioned, and that's really in relation to some of the positive experiences that you had during COVID. You've explained about the camp you were able to attend, and indeed the meeting with Barack Obama. You were also able during that time to complete a chapter for one of your books.
Yes.
Another one of your books, The Routledge Handbook of Disability Activism, won the Taylor and Francis Most Outstanding Handbook Award.
Yes.
Is that right? And you were also, as I understand it, able to continue your work with the Social Care Council Participation Partnership and the Co-Production Strategy Working Group. Is that right?
Yes.
And those were all things that were being facilitated by Zoom calls and remote technology, and your ability to use your laptop independently.
Yes, and sadly, not every disabled person can use their laptop and their technologies independently.
And you set out within your witness statement some of the problems that those people face.
Yeah.
And certainly the inquiry will have regard to those in due
because
course.
there was, at the time of COVID, the pandemic, there was projects to help alleviate that, but they've since lost funding. So that's sad because it's still very much needed, and that should never have been lost. That was one of the things that they should have kept.
Thank you. As I said at the outset, for you, because you are able to use that technology, it was one way of having visitors. It was one way of seeing your family and friends. Another way, as I understand it, in your supported accommodation, was by having people, when the restrictions were relaxed, able to visit in the outdoor spaces.
Yes.
How did that work? Well, they're obviously better than not having visits at all, but I know you raise a number of issues in relation to those.
Yeah, our outdoor space, well, there's a wee small courtyard in the very middle of the building, and it's like a goldfish bowl because there's windows all around it, and it's tiny, and then there's the car park, so that is essentially our outdoor space, and the car park is overlooked by other neighbouring apartments with balconies, and so you didn't have the opportunity to have any private outdoor visits, really. If you had an outdoor visit, everyone joined in. It was like a community event. And even the balcony neighbours, as we called them, they would have like shouted over in the mornings and stuff, "How are you today?" Because the weather was so good. We were outside a lot because that was our only way of seeing people, I guess, off screen. And some people in my supported housing, it felt like they were trying to outdo Sir Captain Tom, the amount they walked around the building, and they were practicing for the Paralympics but it was boredom. It was boredom with people as well.
And one of the things that you raise in your statement is that certainly in the future, people need to reflect on what took place in the pandemic and look at how you could facilitate better visits in terms of buildings functions.
Yes.
So later in the pandemic, you were able to go home to your mum and dad's for coffee in a socially distanced setting outside in the garden. Is that right?
Yes, that was during the time of you were allowed to bubble with another household. My bubbling had to be done outside because I was on the clinically extremely vulnerable list, and at that time I still didn't know why I was on that list, because not all of me, even though we all had disabilities and we all lived in supported housing, not all of my neighbours were on that list, and it wasn't clear ever why we were put on it and why we weren't, and it wasn't until the lockdown lifted and I was able to start going back to my urology appointments that one of my urology doctors I said to him at the first appointment, why was I on the clinically extremely vulnerable list when some of my other neighbours weren't, and they have the same disability? And he said, you were on it because of your bladder, you weren't on it because of your disability. But that was never explained at the time. It was only afterwards. So I guess in the future they need to explain to people why exactly they're on those lists or aren't on those lists, because whenever, particularly when the restrictions started to ease and the world started to go back to the normal, supposedly, that it was before, and people like me that were on the clinical list were still being told to shield, that was very difficult. That was when I felt most isolated, because all the online technologies that I had used to cope during the lockdowns, they were all starting to become sporadic as well, and I felt like I was constantly having to remind people I'm still being told to shield, and that really wasn't a nice experience.
No, indeed, and you point to February 2022 announcement, the Freedom Day as it was billed, when it was announced that all of the remaining restrictions would then become government guidelines. And you posed the question, freedom for who and at what cost? And is that the point at which things became particularly difficult?
Yes, because no one knew, and especially at that time, I think, if I remember it, we were coming up to an election, and I guess the cynical side of me was like, oh, are they only doing this because they want to look good for the public, the general public? And so I was a bit hesitant, but again, that's because they always said, oh, we're following the science, but you were never sure what was science and what was political spin.
In terms of the phrase Freedom Day, did you consider it, and you've already answered this to a large degree, did you consider that this was freedom for you?
No.
If I can now move to when your supported accommodation experienced an outbreak of COVID, and in particular the Omicron period. So we're talking about later in 2021, moving into 2022, that Christmas and winter period. You explain in your statement that your manager tested positive for COVID, and as a consequence, your supported living building decided to enforce a 10-day lockdown, effectively cancelling, in your words, Christmas.
Yeah.
And stop you going home. At the time, the national restrictions did not require that. What action did you take?
I phoned the PHA, the Public Health Authority, and I told him, I forget his name, but it was a male, and I said to him, we've just been told that our building's going into a 10-day lockdown because our manager has tested positive for COVID and she was in the building. And he said, oh, well, you have to do whatever your support provider of your care is telling you to do. And I said to him, but the restrictions for the general public is a lateral flow, and if you don't test positive, then you're free to go out and whatever. And he said, no, you have to do whatever your care provider's telling you. And so I ended the call, and I was angry.
Did you take any further action?
Yes. Because of all, I guess, the campaigning and activism things that I've done, I knew some of the MLAs at the time. So
just to pause you there for those that are following, that's the ministers of the Legislative Assembly.
Members of the Legislative
Assembly members.
And so I phoned one of them, and I said what was happening, and they said, I'll phone you back. And they phoned back about maybe 15 minutes later, and they said, you're right, you're a member of the public, and as long as you test negative on Christmas morning, you can go home. And I said to them, is that the same for everyone in the building? And they said yes. So, and they said, and we've already notified your support staff of that. So on Christmas morning, we all did the lateral flows.
Did you test negative?
Yeah.
Did you go home?
Yeah. But it was the worst wait for that one liner because I don't know how I would have felt if it had been 2 lines. But I was one of the lucky ones because 3 other people tested positive on that morning, and they weren't allowed to go home, but they lived on the other side of the building. They had the shared communal spaces and only a bedroom with an ensuite each, and they weren't even allowed out of their rooms because they tested positive, and they had Christmas dinner by themselves because they weren't even allowed to eat together in case they had different variants. So that's how crazy it was. Even if you had it, you weren't allowed to be with other people that had it on Christmas Day. And even though I was allowed to go home, all that I could think of when I was eating my Christmas dinner was those 3 people sitting in their rooms on their own. So it wasn't nice.
No, thank you. If I can move to a slightly different topic, and it's about the access that you had to medical care and in the hospital. And you do explain within your witness statement the majority of your routine dental and hospital appointments were delayed or cancelled. What impacts can those delays or cancellations have on your conditions and your health?
They can have a lasting impact that you live with every day afterwards. For example, I have a jaw that clicks a lot. It's a rare jaw condition. It's so rare that I get called into the Royal Victoria Hospital dentistry department a lot for the students to look at my jaw. And that can lock at any time. And during the lockdown, all dentists was cancelled, as you know, because they were the ones doing the COVID and testing in the tents. And 2 of my wisdom teeth came up. And I know it might sound like, oh, it's only wisdom teeth. But I was so worried at one point the impact that might have on my jaw, because other wisdom teeth had come up in the past, and I had to get them out because of my jaw not having enough space in my mouth and stuff. So, but thankfully that was okay. But I also had ongoing neurology appointments delayed quite significantly, and it can't be proven, but my bladder health has really rapidly deteriorated since then, and I can't help but wonder, is that part of the reason? No one can give me a definitive answer to that, but urology appointments were cancelled because even specialists were sent to the COVID wards, and clinics and things were we're left as empty wards in hospitals to help out with the COVID wards. I think going forward that there needs to be some distinction made that regular clinics and stuff can stay as long as they meet the required safety elements put in place, because I really truly believe that was one of the detrimental things to my health and ongoing conditions. And I just think it was one of the worst things that happened in the pandemic, and we're still living with really the NHS was kind of collapsing before the pandemic. Now it has collapsed, in my opinion, and they really need to work at building it back, because we can't. We all the way through COVID it was save the NHS, and now it's there's no money to save the NHS.
Can I ask you about one possible solution that you include within your witness statement? And you explain that you were the first resident of supported housing to be signed up for the hospital at home service.
Yes.
Can you briefly explain what is the hospital at home service?
It's a service that if you're already a patient of district nursing or community nursing, that if your consultant can sign you off to go home, you go to A&E and they plan your treatment, and once that's all in place, they sign you to go home with the hospital at home service coming out to give you your treatment. And I've had 2 experiences of that now, and it's a fantastic service. One of the times it allowed me to leave the hospital 10 days earlier than what would have been the case otherwise, and for 3 days while they were coming up with my plan, my treatment plan, I was actually in A&E long stay for the whole 72 hours. So as you can imagine, I was overjoyed to get home with hospital at home, and I was even more overjoyed when it was such a good service. And I got all my medical treatment with the nurses that I knew, and plus I was still able to use my normal domiciliary care package and be in my normal environment, and I healed quicker because of it, because it was with people that knew how to help me and support me. Because quite often in hospitals, nurses aren't used to dealing with people with extra complex needs due to disability, and so it makes it harder because you're not well, plus you have to teach people how to look after you while you're not well. So the hospital at home is fantastic in my experience.
Thank you. And in terms of your care review, obviously you have frequent care reviews, normally undertaken face to face, but in the pandemic it was undertaken, as I understand it, by telephone.
Yes.
And you explain, while you are able to use digital devices and technology,
Yep.
Your care manager was not.
Yes.
She had difficulties. They had difficulties actually using the technology.
Yeah.
What impact did that have on your care review, your plan?
Well, it wasn't face to face, so she was relying solely on my voice and what I was telling her, and when they come out to do a review, normally they're able to read your notes and your files and they're able to maybe see the condition in which you live and just see any general signs of good care or neglect either way. And over the telephone, that, in my opinion, that was a very missing element, and it could put people at risk potentially. I'm quite able to speak up and say if I'm not getting something I should. But there's other people that you heard even just this morning that would be afraid to speak in that regard. So face-to-face is definitely needed for that type of thing, even if it is online. But all professionals in that area do need to be kept up to speed on modern technology. It's not good enough for them just to assume that, oh, they're a service user, they probably won't be able to use it, so we don't have to worry about learning it. It should never be that, because we're all different. And although some disabled people can't use technology, there's a lot that can. And there specifically a lot of people with autism or neurological issues or disabilities, they actually like interfacing with the screen opposed to reality. So there is evidence out there that works for some people better than face to face.
And in fact, I'm going to bring you on to a related topic in relation to some of your observations, and that's your experiences of inspections in terms of the Regulation and Quality Improvement Authority. And you describe within your witness statement one inspection during the pandemic that was an in-person inspection, but they were not able to come into rooms to conduct private interviews. Instead, they met everybody in the open doorway of their rooms. Is that right? What impact did you see that having, or could it have had?
Well, as I've said before in previous answers, our outdoor space was far from private, and so if you were having a private issue, you wouldn't want to tell someone standing at your front door, and not just because the care provider could overhear, but because your neighbours could overhear private, confidential details about your personal experience and life. And I think to mitigate that in the future, if you are able to use technology, they should say to you, if there's stuff today that you would have liked to have spoken about but didn't, is it okay if we follow up with you over Zoom or something? But there was nothing like that, and although it was kind of good that they come out and did the face-to-face, because at least one of the first questions she asked me, I'll never forget it, was, we're just out to check how you're doing. I thought they're out to check if I'm still alive from COVID, and because it was at the, pretty much, I think it was the first summer of the pandemic anyway, so it was pretty early on.
Indeed, since then you've had, most recently, in fact last week, an unannounced inspection visit, is that right?
Yes.
And as a consequence of that, you've been able to compare those experiences.
Yes.
And on this occasion, they were able to conduct private interviews, obviously not subject to the COVID restrictions. but they also gave everybody questionnaires to send back after the inspection.
Yes.
Is that something else that could be done within pandemic conditions to try to enable
Yes.
people to be able to speak freely?
Yes. And I also noticed in comparison with other inspections that this one was very general, where before in the past they've always been very focused on an issue or a topic, and this one was general, and I think that was a good thing, because I think sometimes if they're too focused on a topic they could potentially miss stuff, if they're only questioning people around a specific area. And so I thought the generalisation was good, because it allows you to have a co-produced agenda with them. Maybe that's not such a
It provides
good word.
perhaps with an opportunity
Yeah.
to express things that are not
Yes.
within the topics they identify.
Yes.
May I now turn to a distressing subject, and that's in relation to the do not attempt cardiopulmonary resuscitation notices and letters that we've heard were disseminated during the pandemic to various individuals. You did not receive such a notice, did you?
Not that I'm aware of.
But you were at the time aware that others in similar positions to you had done so.
Yes.
How did that make you feel? What impact did that have on you?
I thought it was wrong, and very wrong, and I was glad when the World Health Organization and stepped in to correct it, but in that correction they come up with a point system, which was in effect the same outcome. Only it was less evident, because people like me would have scored differently than an able-bodied person, or not just an able-bodied person, a healthy person. So technically we were still more susceptible to not being saved over a healthy, someone that was deemed healthy, and more, I suppose, societally worthy of saving their life. That's what it felt like. So even though they done away with the do not resuscitate, that point system in a way was still a do not resuscitate, only invisible.
Were you concerned that such a notice would apply to you, or that you'd receive a letter of that nature during the pandemic?
I always just hoped I wouldn't have to go. I wouldn't have to go to hospital in that regard, and I'm very thankful that I didn't, because I did take COVID at one point, and I was very lucky because it only affected me that I had a sore throat. That was it. I wouldn't have known I had COVID, only I did a lateral flow for actually a urology appointment when urology started to come back. And they phoned me and they said, "You've tested positive for COVID." And I laughed. I thought they were winding me up. And they were like, "No, you have. You've tested positive. You need to isolate. We've already notified your care." And right enough, the next thing, the cars were up the door, and they were dressed like something out of Star Trek, Dark Theater. But I can laugh about it now, but at the time I was like, I feel okay. Are you sure you haven't mixed my results up with someone who's really sick? they could be spreading it, and they were like, no, it's definitely you. And so then for maybe a day or two, I kept thinking, I still don't feel sick, but I kept waiting thinking, well, they told me I have COVID, and I was still going to my online meetings, and people were saying to me, you don't look like you have COVID. So it just highlighted to me that even though I was on the extremely vulnerable list, there was some people who were not, didn't have any underlying health issues or disabilities, and COVID hit them harder. So again, I would like to know how, kind of in the future, I would like for that list, maybe for the requirements of that list to be co-produced, because I know they were doing their best because it was unprecedented and they didn't know, so I'm not having a go at them in any way. And if anything, I'm glad that Robin Swan was our health minister at that time, because he stood up against a lot of legislative criticisms, and from within the legislative assembly itself, as well as the general public, to safeguard us. And even though he grounded me for 700 plus days, I will always be thankful that he did stand up in the unknown. And so we can't kind of the legislators for legislating in the way that they did in the unknown. But that being said, I do hope that they learn from it and could produce and do things better if it ever happens again. And that includes building designs and air purification and things like that.
Thank you. Turning to a related but different topic, sadly 4 of your neighbours in your supported accommodation passed away during the pandemic period when there were restrictions in place. These were not from COVID,
Yeah.
but nonetheless, obviously, the restrictions in relation to the funeral proceedings applied.
Yes.
What impact did that have upon you and your ability to grieve your friends?
Well, we couldn't obviously go. Before COVID, we all would have went to anyone's funeral who passed away. That was kind of the done thing, and then COVID hit, and we didn't do that, and some of them were at the very beginning, so there wasn't even the online service. It was very strange being handed like a card in memory of a person and not having that same closure that you were used to. I guess it still feels very surreal. Again, I guess that was unprecedented too, but that was one of the hardest things for people during the pandemic, that they couldn't grieve in their normal process and way, and I guess that was never really addressed in any way, even as the lockdowns were the restrictions were kind of lifted. It was just gradually it went back to normal, and services were live streamed, which was a nice thing, because for example, one of my aunts in Australia died, not of COVID, and after the pandemic, But unlike my other relatives who passed away in Australia, I was able to go to her funeral, so that was a nice thing to come out of COVID. So I think we have to think about what was good that came out of COVID and what we need to keep as because a lot of what I think we needed to keep is starting to disappear. So, yeah.
Thank you. And Ms Sansome, just finally, importantly, you've shared your experiences in a number of different forums, including obviously today at the inquiry. What was the most important point that you sought to get across then and you seek to get across today?
I really think co-production and deliberative democracy is key to living up to that slogan of building back better. I think legislators have to get past the fear of it and embrace it for what it is. It's an opportunity for everyone to be involved in the legislations that's going to shape society and their daily lives. It's an opportunity for everyone to have a voice and everyone to be heard and ensure that nothing about us without us becomes reality in all legislation, not just disability legislation, because all legislation impacts disability. We are intersectional of all communities, the disability community, so we need to be included in all legislation going forward. And that is a way to do it, because deliberative democracy draws on the statistical data of the census and ensures that there's a proper cross-representation of society, giving recommendations to the legislators. It doesn't take over the role of legislators, it assists legislators and builds trust in the legislative process, and that is sadly lacking in today's society, and that is one way to build it and build a better society and live up to what they said and build back better.
Thank you very much, Ms Sansome. I certainly think that's taken on board in terms of co-production in relation to what you would say lessons to be learned for future pandemics. Thank you, my lady. Those are the questions that I have.
Thank you very much indeed, Ms Sansome. I can confidently say no other witness to this inquiry can say, as a result of the pandemic, I met a former president of the United States of America. So that's a first. So I'm glad at least something positive came out of it. You've been an extraordinary witness, and I'm delighted you were able to join us. Thank you so much for all your help and taking the trouble with your supporters to come over here today. I hope you feel it's been worthwhile, because I certainly do. So thank you very much indeed.
Thank you, and if there's anything further I can do to assist.
Well, you're obviously an extremely effective campaigner, so I'm sure that if anything else occurs to you, you'll let us know too, but we'll let you know.
Thank you so much.
And safe journey back to Belfast tonight, I gather.
Thank you.
I hope it's not too... It must have been a very long day for you.
I land back in Belfast at 11 tonight, so yeah.
That's not very good. I'm sorry it's been such a long day for you.
That's okay. It's been a really good experience.
Good. Yeah. Delighted.
Thank you.
And I hope I'm sure, knowing how efficient the team are, I'm sure you've been looked after.
Yeah, they've been fantastic the whole way through.
Smashing.
So they have.
Okay. Thank you very much indeed. I shall return at 10 o'clock tomorrow.
All rise.
Bye.